Hello and welcome. My name is Unruh. I'm an assistant professor of clinical surgery for Louisiana State University in New Orleans, Louisiana. Today I'm going to be talking about diagnosis and treatment of chronic venous insufficiency. I'd like to thank Dr. Walker and NCVH for having me. Chronic venous insufficiency describes complications from the presence of high venous pressures in the lower limb, resulting in cutaneous changes. And here you can see many of the cutaneous changes ranging from telangiectasias, reticular veins, varicose veins, superficial phlebitis, skin changes, and finally, venous ulcerations. To understand venous pathology, you first need to understand normal venous anatomy, which is comprised of three different systems: the deep, the superficial, and the perforating veins. The superficial venous system starts with the greater saphenous vein and its multiple tributaries, which you can see in this photo. The great saphenous vein has many variations within the saphenous sheath and tributaries. In the first one, we can see the saphenous sheath with one vein. In the second, the vein branches into two separate veins within one sheath. In the third, there's an H vein where one vein runs through and then a large branch exits the sheath. In the fourth one, there's actual anterior saphenous with its own individual sheath. And in the fifth one, it exits the sheath entirely. The superficial venous system has multiple accessory branches, including the posterior and anterior accessory in the greater saphenous vein of the thigh, the posterior and anterior accessory greater saphenous vein of the leg, and the posterior and anterior thigh circumflex vein. Here you can see an example of anterior circumflex reflux. You can see that the vein is running anteriorly and laterally along the patient's leg. And here's a diagram showing the anterior and lateral distribution of this anterior circumflex vein. Next, we're going to talk about the small saphenous vein and its multiple tributaries. Here are examples of small saphenous vein reflux. You can see here outlined many varicosities, and here is a bulging small saphenous vein. The vein of Giacomini typically connects the small saphenous to the great saphenous system. And here's an example of the Giacomini vein reflux, where you can see it's connecting laterally and medially. Now, the perforators have old terminology: Hunters, Dodds, Boyds, and Cockett's. However, we now use the new terminology: the anterior thigh, posterior medial thigh, femoral canal, paratibial, posterior tibial, and medial ankle perforators. Now we'll speak for a second about the deep venous system. Here you can see the deep femoral vein, the popliteal vein, and the multiple tibial veins. May-Thurner syndrome is a syndrome which affects the left common iliac vein as it runs under the right common iliac artery. This is an IVUS picture, or intravascular ultrasound, where the catheter is placed inside of the vein, and here you can see the artery compressing on top of it. So this is left iliac vein being compressed by right iliac artery on top. Now, the SEEP classification is a classification that we use to describe all venous disease: clinical, etiologic, anatomic, and pathophysiologic classifications. For the purposes of this lecture, we are going to discuss mainly the clinical classifications. So this is in 6 different segments. C0 is normal. C1 are telangiectasias, or reticular veins, which you can see here in this image, the typical what is so-called spider veins. C2 are varicose veins, which are veins that are greater than 3 millimeters. in diameter, and these have a bulging, often tortuous appearance, although they can be tubular and also demonstrate reflux. Moving along, C3 is edema, and C4A is pigmentation or eczema. And here you can see a picture of the erythematous dermatitis, which can progress to a blistering, weeping, or scaly eruption of the skin, which you can see that scales kind of appearance right there. C4B is lipodermatosclerosis, which is a localized chronic inflammation and fibrosis of the skin and subcutaneous tissues. And here you can see the typical appearance, kind of this reddish, woody kind of appearance. C5 is a healed ulcer. And here you can see the appearance of a fully healed ulcer. And C6 is an active ulceration. To touch for just a minute on pathophysiology, the venous pump function mainly comes from the calf, foot, and thigh. The calf has the largest venous capacitance in the soleosinusoids and generates the highest pressures during contraction of greater than 200 millimeters of mercury. Abnormalities in the valves or lumens of the vein can impede the pumps, and vein dilation seems to cause valve dysfunction, not vice versa. All of this leads to a state of persistent ambulatory venous hypertension, which leads to our different clinical classifications. What causes vein valve damage? Well, post-thrombotic damage to the deep venous system can cause vein valve damage. Vein wall weakness of the saphenous system can cause vein valve damage. Incompetent perforator veins connecting the two systems can cause the valve damage. And there is congenital valvular agenesis. Treatment starts with conservative measures. Elevation when possible. Standing and sitting are the worst positions. Anything in a dependent position is going to be more difficult. However, you can't expect people to not stand or sit all day. And then there's compression therapy, which accelerates capillary flow and filtration, is graduated, and reduces overall edema and discomfort throughout the day. There are different classes of compression therapy and different pressures of millimeters of mercury of pressure that go along with those classes. Drawbacks for compression therapy are they're very uncomfortable. They can be too tight, too hot, too hard to get on. And most of my patients, when they start feeling comfortable in their compression hose, it's when they've worn out and it's time to get new ones. And there are contraindications to compression therapy as well. You don't want to wear them with weeping wounds. Those would probably be better served with a wrap or an Unruh administration, or peripheral arterial disease. You don't want them to be too tight and impede actual arterial flow to the foot. There is drug therapy available, Trental, which has shown some efficacy with combined compression in improving venous ulcerations. And here's just kind of a brief history of surgical varicose vein treatment. Starts with Celsus, with stripping and cauterizations of varicose veins around 30 BC to 30 AD. Galen then recommended tearing the veins out with a hook, which we still do today. It's called stab phlebectomy. Paulus performed ligation and stripping of vein segments. William Harvey really delineated how blood flows from arteries to veins and taught that actually treatment could be often worse than the cure. Modern anesthesia was induced in 1850 and surgical vein stripping became common in 1950 and was for many years considered the standard of care. So to touch on surgical vein, greater saphenous vein stripping for a second. Greater saphenous vein stripping versus high ligation achieves excellent results. High ligation meaning just ligation of the saphenous vein close to the saphenofemoral junction. There's a much lower recurrence rate with greater saphenous vein stripping and a higher intermediate success rate. The operative technique, a small incision is made proximally, and extensive tributary ligation is performed in that area. So all those little branches that contribute right before the saphenofemoral junction. Then division of the vein at the saphenofemoral junction. A stripper is attached and inverted to the level of the knee, and then the whole vein is removed. Saphenous nerve injury occurs when the vein is avulsed 7 to 13 centimeters below the knee. It occurs in 60% of patients with saphenous vein stripping to the ankle level, but only 6% of those patients reported that the lifestyle was actually affected. Stripping the greater saphenous vein to the ankle is not necessary, and the knee level is sufficient. Now we're going to talk about what's more commonly done these days, endovenous ablation. This involves thermal damage to the vein and intimal destruction with collagen denaturation of the media and fibrotic occlusion. There are two ways to achieve this, either through radiofrequency ablation, or RFA, or endovenous laser, EVLT. Anesthesia for these procedures, you want to use tumescent anesthesia, which is a lidocaine epinephrine solution injected into the perivein tissue and hopefully inside of that saphenous sheath to prevent dermal damage and also saphenous nerve injury. It can be done under a regional block or under general anesthesia, or simply in the office with sedation and the tumescent anesthesia. So in order to achieve this, you first access the vein under ultrasound guidance distally. You advance a guide wire and then a sheath. A probe is advanced to the saphenofemoral junction if you are doing the greater saphenous vein, or the saphenopopliteal junction if you're doing the lesser saphenous vein. The catheter tip is then positioned for the great saphenous vein 1 centimeter distal to the inferior epigastric, and for the less saphenous vein 10 to 15 millimeters distal to the saphenopopliteal junction. The patient is placed in Trendelenburg position and tumescent anesthesia is administered. The position is then rechecked with ultrasound. The vein is ablated in a retrograde fashion, which means that you either slowly remove with the EVLT or treat in segments with a radiofrequency ablation in a retrograde fashion. The catheter is then removed and the entire saphenous is re-imaged to make sure that A, you don't have a deep vein thrombosis, and B, that the ablation has been successful. You can also combine this procedure with adjuvant therapy for avulsion of varicose veins more distally, or sclerotherapy if needed. Here's another image of the catheter inserted into the vein. The vein heats it and collapses the vein, and then it's withdrawn and the vein is closed. Here is an image of stab phlebectomies, which again can be used as an adjunct. We use this little hook right here. You make a little incision in the skin, the hook is inserted, and the vein is kind of plucked out, removed from the tissues, then ligated as much as you can of it. To discuss radiofrequency ablation a little bit more in depth, this is a computer feedback controlled bipolar electrothermal energy machine. It does transmural heating of the vein wall and minimizes spread to the surrounding tissues. It uses either a 6 or an 8 French catheter, and a radiofrequency generator is used to create resistive heating. This is just an example of the closure fast device. 7 French catheter, it treats 7 centimeter segments at a time, and it treats veins from 2 to 15 millimeters in size, and the entire length can be treated in 3 to 4 minutes. Again, the procedure steps: the catheter tip is positioned at the superficial epigastric vein, tumescent anesthesia is administered. There are markings on this catheter that tell you exactly where the 7 centimeter segments are. The segment centimeters are treated all at once using a 20-second treatment cycle, and then it's removed so that you treat one segment and then another segment and then another, and so on until the entire vein has been treated. Now to speak to endovenous laser therapy. This is a laser energy delivered through a 600 millimeter fiber. It causes the blood to boil, which results in steam bubbles, which causes collagen contraction and endothelial damage. There's similar positioning of the patient as for radiofrequency ablation. The differences are, this is faster than the original radiofrequency ablation device, and there's no vessel size limit as there is for the radiofrequency ablation. Post-procedurally, the patients are put in a compression stocking or wrap continuously for 2 weeks, and then when walking or standing for 6 weeks following. Early ultrasound evaluation at 1 to 3 days is used to confirm success and make sure that you don't have any kind of complications such as a deep vein thrombosis. Complications from this procedure can be minor, from bruising, bleeding, paresthesias, phlebitis, pigmentations, or burns, or major. Up to 6% of patients can have DVT, and PE, thankfully, is very rare. For the DVT patients, we put them on anticoagulation and re-image in 6 weeks. Here you can see an image of clot extending into the femoral vein, right here. This procedure yields excellent short-term results. 97% have vein occlusion at 1 week, and of those, 99% remain closed at 6 months. Less than 6% had pain that lasted greater than 1 week. And here you can see a vein that has been completely ablated. Long-term results are generally better than vein stripping. Follow-up as long as 3 years shows low recurrence rates. There's minimal pain, and patient satisfaction and return to work is better and faster. Just to talk for a second about sclerotherapy, there's polidocanol, which is FDA approved. It can be administered as a foam, and it is injected into tributaries, veins that are not amenable to endovenous therapies. Also, there is perforator interruption. Linton described actual surgical interruption of all the perforators open in the 30s. Then there was the SEPS procedure, which is actually a minimally invasive procedure, which also surgically removes the perforators. You can inject these perforators with sclerotherapy or use endovenous ablation as well. However, there is a higher rate of DVT with this. So for venous ulceration treatment, you can attempt conservative therapy. You definitely need to treat superficial vein reflux. Always ablate the perforator if there is one beneath the ulcer, and use compression always in these patients. Thank you very much. I've appreciated all of this, and thank you for listening.